Before going to GERD, I'll explain you what is the lower esophageal sphincter and what is the definition of incompetent LES. Okay. As I've told you, the total length of LES, total length of LES is 5 centimeters. Intra-abdominal length 2 centimeter. Pressure is 6 to 26 millimeter of mercury. Okay, this is normal LES. Whenever the total length of esophagus goes less than 2 centimeter or the intra-abdominal goes less than 1 centimeter or the pressure goes less than 6 mmHg, it is known as incompetent LES. Okay, so whenever there will be the function of LES, as I'll explain, is to prevent reflux. Okay, whenever there will be incompetent LES, there will be more and more reflux and it will leads to GERD. Okay, the gastroesophageal reflux disease. So GERD occurs because of incompetent LES. What are the components of incompetent LES? Total length less than 2 centimeter, intra-abdominal less than 1 centimeter, pressure less than 6 millimeter of mercury. Okay, due to this incompetent LES, there will be reflux symptoms. The most common symptom as shown in this table is heartburn. Okay, so they will ask what all among the all options, what is the most common symptom? They'll give heartburn, regurgitation, abdominal pain and other things. So the best answer will be heartburn. This is very important. Most common symptom is heartburn. So there is no need to remember everything. Just focus on this heartburn, because as you know that the other symptoms will be regurgitation, pain in the abdomen, cough or some other symptom, but the most common will be heartburn. Okay. This reflux will lead to esophagitis followed by ulcers in the esophagus. These ulcers which gradually contract, leading to fibrosis and leading to stricture. Okay, leads to fibrosis which leads to stricture, and there will be development of columnar metaplasia or Barrett's esophagus. Columnar metaplasia or Barrett's esophagus, which later on leads to adenocarcinoma. Okay, so now this is a pre-malignant condition leading to adenocarcinoma. Okay, so the GERD leads to fibrosis, stricture, ulcers, columnar metaplasia, Barrett's esophagus and adenocarcinoma of the esophagus. Okay, now this incompetent LES I have already told you. This is very important, I am repeating it again. Less than 2 centimeter total length, less than 1 centimeter intra-abdominal length and less than 6 millimeter mercury pressure of the lower esophageal sphincter is incompetent LES. Now what are the clinical features of GERD? This is retrosternal, there will be burning. Along with that there will be pain in the epigastrium and there will be regurgitation. Okay, so that this is a classical triad of heartburn, epigastric pain, and regurgitation. Heartburn, epigastric pain and regurgitation. Among these all three, this heartburn is the most common symptom. Okay, now we'll go for investigation to diagnose this GERD. What is the investigation of choice? The investigation of choice will be 24-hour ambulatory pH monitoring. Okay, suppose on this ambulatory pH monitoring we have identified that there is a reflux. Okay, now there is a reflux. How we'll go about it? How we'll treat it? The treatment will be initially PPIs, and if the disease is not controlled on PPIs, we'll have to later on go for surgery. What is the surgery of choice for this GERD? This is fundoplication. Okay, clear? So the investigation of choice will be 24-hour ambulatory pH monitoring. What we will calculate in this ambulatory pH monitoring, that how many times there is reflux, how many times the pH is less than 4, how many times there is reflux in the upright position, and whether it was associated with the symptoms at the time of reflux. All these findings will lead to calculation of a score, which is a D-Meester score. Okay, D-Meester score, and this D-Meester score, if it is more than 14.7, it is diagnostic for gastroesophageal reflux disease. And now what is the management? As I have told you, the management initially will be lifestyle modification. Lifestyle modification. If there will be improvement, then it is good. Otherwise, we will go for double dose PPI. And if it is not improving, then we'll go for fundoplication. Okay. Now this lifestyle modification, we have to do a few things, like we have to avoid smoking, decrease our caffeine intake, and we'll have to avoid large meal before going to bed. Okay, decrease our caffeine intake, okay, avoid smoking, and avoid large meal before going to bed. Okay, then the next point is double dose of PPI, and after that we will have to go for fundoplication. Okay, now before fundoplication, we will have to do a few tests. Okay, 3 tests which are mandatory. Before fundoplication are obviously 24-hour pH monitoring, to diagnose the disease, diagnosis of GERD. Second, we'll do a barium swallow. To rule out sliding hernia. As sliding hernia is also associated with gastroesophageal reflux disease, as I have already told you. And we'll also go for upper GI endoscopy and biopsy. Okay, why upper GI endoscopy and biopsy? It is done to rule out Barrett's esophagus or Barrett's mesoplasia. To rule out Barrett's esophagus. Okay, if there is a large sliding hernia, suppose there is a large sliding hernia while going for surgery, fundoplication, if we know that there is a large sliding hernia or there is any other hiatus hernia associated with it, then we can plan our surgery better. Okay, and in case if there is associated upper GI, if there is associated Barrett's esophagus, then we'll take a biopsy to confirm this Barrett's esophagus, and we'll rule out presence of dysplasia. Okay. In case if there is high grade dysplasia, patient might need esophagectomy. Okay. So we'll have to rule out dysplasias in Barrett's esophagus before going for fundoplication surgery. Okay. Now, what is the treatment of choice? Treatment of choice or the gold standard treatment is laparoscopic Nissen's fundoplication. Okay. Laparoscopic Nissen's fundoplication. This Nissen's fundoplication is 360-degree fundoplication. Okay. Now, there is a very commonly people are asking questions regarding the types of fundoplication. This is a very hot topic few years back. Types of fundoplication. Okay. So, I'll discuss them one by one. Before that, we'll have to understand what we do in fundoplication. Okay. So this is normally a esophagus, this is G junction, and this is stomach. Now, stomach fundus is supplied by short gastric vessels. We are dividing these short gastric vessels, and this makes fundus free. Okay. Now, this fundus is taken either behind the esophagus or in front of the esophagus. You got my point? Either behind, if this is esophagus, this is stomach, the fundus is either taken from behind the esophagus, and then there will be fundus on both the sides of the esophagus, and then we'll join these two fundus together over the esophagus to form a wrap. Okay, so it is also known as wrap surgery. Okay, we'll form a wrap, and if we are taking the fundus from posterior to the esophagus, this will be known as a posterior wrap, and if we are taking it anteriorly, it will known as, we'll call it as anterior wrap. Okay, so now there can be posterior wraps or there can be anterior wraps. Okay, so this posterior one, if it is 360-degree, it is Nissen's fundoplication. Okay, this Nissen's one is the most commonly performed and preferred. Okay, if it is posterior 270-degree done laparoscopically, then it is known as two-pay fundoplication. Okay, and if it is laparoscopic, if it is 270-degree done transthoracic, then it is Belsay Mark 4 is done transthoracic. Okay, we can mobilize the G junction from the chest also, as it is associated with short esophagus, and after that we can make a wrap, push it down, and then we can close the defect, diaphragmatic defect. Okay, this is Belsay Mark 4, and along with that, if anterior, if it is anterior 180-degree, it is Dor, and if it is 90-degree anterior, it is Watson. So this Watson is not a very good fundoplication, poor outcomes, and is not done nowadays. Belsay Mark 4 is also not done nowadays because it is transthoracic. Generally we prefer abdominal. So this Nissen's fundoplication, two-pay and Dor are the ones which are preferred nowadays. Okay, now there is a diagram. We'll have to identify the type of fundoplication. Just go ahead. This is esophagus. This is stomach. There is the fundus. some part of the fundus is going behind the esophagus, coming here, and the other part is coming from anteriorly. So it is 360-degree and is nascent fundoplication. Okay, and if it is going posteriorly, anteriorly it is free. Here you can see this area is free. I'll mark it with red. Here this area is free. Okay, so this is posterior toupee. Okay, toupee or posterior 270-degree. Okay, now this is what? This is only anteriorly we have taken the stomach. This is door fundoplication anterior. Now coming to a very important topic or a very important problem which is frequently encountered during surgeries for GERD. As I have already told you, incompetent LES is associated with short length of lower esophageal sphincter and short length of intra-abdominal esophagus. So now there is very short length of intra-abdominal esophagus. Making a wrap along the esophagus is not possible. Okay. So in these cases, even after mobilization of the intrathoracic esophagus, the esophagus is not coming down. So this is the problem of short esophagus, which is very commonly seen in this GERD. So in these patients, we'll have to do something like this. This is very short esophagus. There is, you can see the diaphragm. We'll make a hole here, fire a staple. This will increase the length of our esophagus, and then with the remaining this fundus, we will wrap around it. Okay. So this is what is known as Colles gastroplasty. So this Colles gastroplasty is done in short esophagus, done to increase the length of the intra-abdominal esophagus, and along with that, after that, we will do fundoplication as a routine. Okay, this is the diagram for Colles gastroplasty. So now GERD, I have already told you, GERD is associated with these problems also. Dysphagia. Okay, dysphagia in GERD is generally associated with stricture. Due to this chronic inflammation, there is development of stricture. For this stricture, we will have to go for first endoscopic dilatation. And if it is not responding, then we'll have to go for surgery. Generally, we prefer endoscopic dilatation. Majority of cases are treated well with endoscopy, which is the treatment of choice. Okay. Now, obesity in GERD. If a patient is morbidly obese, and along with that patient is having GERD, the treatment of choice is Roux-en-Y gastric bypass. Okay, not a sleeve gastrectomy. No sleeve gastrectomy. Okay. Why? Because in sleeve gastrectomy, there is increase in the pressure of the tube because the tube is narrow, and there is distally there is pylorus antrum, which is also acting as another way to increase the pressure of the tube. The tube is small and there is a narrowing at the lower end, which is the normal antrum and pylorus. So there will be increased pressure, and it is a refluxogenic procedure. It increases GERD. Now, if a patient is already having GERD and along with that morbidly obese patient is there, and if a patient is going for bariatric surgery, the procedure of choice in this patient should be Roux-en-Y gastric bypass. That is why we always go ahead for upper GI endoscopy in a morbidly obese patient, just to rule out presence of any hiatus hernia or GERD. And in case if there is presence of hiatus hernia or GERD, we will prefer Roux-en-Y gastric bypass in these patients. Now the next point is Barrett's esophagus. Barrett's esophagus, what we see in Barrett's esophagus is something like this. There is presence of tongue-like protrusions. You can see here, tongue-like columnar protrusions. Okay. So now there is a patient. I'll tell you the question. There is a patient having complaints of GERD on upper GI endoscopy. This is what is the diagram. What is the diagnosis? The diagnosis is Barrett's esophagus. Okay. I'll discuss regarding the Barrett's esophagus in few minutes. Now the next point is partial versus complete fundoplication. In partial versus complete fundoplication, the preferred surgery is complete fundoplication. Okay. Sometimes they might try to confuse you that there is presence of ineffective esophageal motility. Or the esophagus is not able to push the content well inside the stomach. So in these cases, we can go for partial fundoplication, but as far as the recent studies are concerned, the result of partial and complete fundoplication are the same. So in case if they are asking you regarding the ineffective esophageal motility, I will suggest you to go for a partial fundoplication option. Otherwise, you should go for a complete fundoplication or a Nissen's fundoplication. Okay. Now, regarding this Barrett's esophagus may there is presence of columnar metaplasia. Due to this chronic reflux and chronic GERD, there is presence of inflammation, esophagitis, ulceration, stricture, or there is presence of Barrett's esophagus. This Barrett's esophagus is presence of columnar metaplasia. Normally, the normal esophagus is having non-keratinized squamous epithelium, but due to this chronic reflux, it develops columnar metaplasia. The interesting finding along with this columnar cells is the presence of goblet cells. Okay, and that is why it is also known as intestinal metaplasia. Okay, normally the goblet cells are present in intestine or the small intestine. Okay, so what is the investigation of choice? The investigation of choice is upper GI endoscopy and biopsy. Okay, what we will see on upper GI endoscopy, that there is pale squamous mucosa of esophagus here, and along with that there is presence of tongue like protrusion, and there is presence of red velvety columnar epithelium. Okay, and what is the treatment? As it is associated with GERD, we will go for fundoplication. Okay, normally in cases of GERD, we may wait for this lifestyle modification or PPIs, but in case of Barrett's esophagus, we will have to go for fundoplication. Okay, and along with that, there will be routine endoscopic surveillance. Routine endoscopic surveillance, which is done every 1 to 2 years. Why? To rule out dysplasia. Why? Because it is a pre-malignant condition and it leads to development of esophageal adenocarcinomas. Okay. So now what all are the complications of anti-reflux surgery? So the most common complication after anti-reflux surgery is post-operative ileus. So we'll have to go for post-operative ileus. Okay, this is important. Not pneumothorax, not any other thing. It is post-operative ileus. This is a barium picture in which what we can see here, this is a wrap which is present inside the chest. So this is a slipped or migrated wrap, which is also a complication. This is important. Okay, along with that, two new devices which are used endoscopically for the management of GERD, given in Bailey also, this recent Bailey. So this is very important for you guys. You might get a question on this. We can do transoral incisionless fundoplication, which is a type of notes again, natural orifice surgery. Okay, transoral incisionless fundoplication, esophagus. Okay, you can see fundoplication used in GERD. Okay, endoscopic used in GERD. Now there is only implantable magnetic sphincter augmentation device. Why we are augmenting sphincter? Because there is incompetent LES. Okay, so this is used in GERD. What is the name? Links. So there are two important questions. These 2 points are given in Bailey. You must remember esophagus and links are the two things which are used in management of GERD. Esophagus में we are fixing. Okay. There is some suturing you can, this is just to remember how you can remember. It is to fix or to suture. We are doing some fundoplication here. But this is magnetic sphincter augmentation device, or MSAD is links. Okay, this is few points about GERD. Now this is a diagram which we'll see in stomach in detail, but whenever there is presence of GERD or presence of hiatus hernia, okay, in hiatus hernia, in type 2 hiatus hernia, there is presence of stomach here. Type 2 hiatus hernia or type 3 hiatus hernia or the paraesophageal types of hernias. The stomach is present in the chest. Okay. Gradually, this stomach will go up, and there will be development of gastric volvulus. Okay. So this gastric volvulus, this is what kind of gastric volvulus? You can see here the stomach is rotated like this. So this is organoaxial volvulus along longitudinal axis of stomach. So this type 2 or 3 paraesophageal hernias are associated with organoaxial volvulus. Okay. This we'll discuss in stomach, but this picture is important. And this is gastric volvulus, organoaxial type of volvulus.